like right out the hallway. We're at the ED like waiting area.
Awesome. So should we get started now or give it a couple of minutes for more people to arrive?
I think we can start now. It's 11.
Okay.
Thank you.
So without further ado, I want to thank everyone. This is for joining the University Hospitals Health Services Research Grand Rounds, supported by the UH Health Services Research Center. My name is Matthew Mirsky. I'm a thoracic medical oncologist, and my research focus is on equitable clinical trial enrollment in our community. I'm going to be the moderator for today's talk. Before we get started, there's a few housekeeping notes. The webinar is being recorded and will be available to view from the UH Research and Education Institute website. Please mute your microphones throughout the presentation. If you are to require technical assistance, please contact the research and education team, which would be Nicole Bollinger or Abigail Zona, who are also on the call. If you want to ask questions, go ahead and leave them in the chat. They can be seen either by everyone, or you can have the option to submit them anonymously. So with that, it's my pleasure to introduce our speaker, Dr. Kiran Faryar. Dr. Faryar is a practicing board-certified emergency physician and clinical researcher with a focus on integrating public health and public health services into emergency department settings. In 2021, she was appointed a research director for the Department of Emergency Medicine at University Hospitals Cleveland Medical Center, where she oversees departmental research infrastructure, capacity building, and faculty research development. Her primary research work is in the field of implementation science, investigating screening, and intervention best practices in the ED. She has initiated, managed, and disseminated community health projects in both academic and community EDs, including HIV, HCV, and latent TB infection screening and linkage to care, take-home naloxone distribution, initiation of medication for opioid use disorder, for ED patients with opioid use disorder, with next-day linkage care, county-wide COVID-19 testing through an $18 million COVID program funded by the CARES Act. She has published numerous peer-reviewed publications in top-tier emergency medicine and public health journals, and has been awarded numerous industry, local, state, and federal grants for her public health and health services. On a national level, she's the chair of the Society of Academic Emergency Medicine Research Directors Interest Group and an active member of the SAEM, which is the Society of Academic Emergency Medicine, MTIDE, which is the Emergency Medicine Transmissible Infectious Disease and Epidemics Interest Group. Without further ado, please join me in welcoming Dr. Faryar to give our talk today.
Thank you so much for that warm introduction. I'll go ahead and take a minute and share slides here. Okay. All right, so you should all be seeing the presentation in presentation mode, is that correct?
Yes, we can see it.
Perfect, thank you, Yi. So thank you so much for having me. I wanted to take the next approximately 45 minutes to really discuss what does health services mean in emergency medicine and specifically the ED setting. As he said, my name is Kiran. I'm an emergency medicine physician by training and the director of research in the Department of Emergency Medicine. Here are my disclosures. So first, a little bit of fast facts about the ED. We may see this or experience this when we come down for visits, but we wanted to put some numbers behind this. So in 2022, nationwide, there were approximately 140 million ED visits. In comparison, or as just kind of a benchmark, there were over about 400 million primary care visits in that same year. So for ED specifically, this accounts for 43 visits per 100 person years. A 2017 report identified that emergency departments contribute to almost 50% of all hospital delivered medical care that's provided. As you can see here in this graph, it indicates the number of ED visits in the United States. Most notably in 2020, we saw this dip in visits, and this was due to COVID, and now we're rapidly rising up to pre-COVID numbers. So the emergency department really is considered the healthcare safety net, and that's for many reasons. One, we treat everybody, specifically regardless of ability to pay. We are a 24/7, 365 operation, and we have a federal mandate. EMTALA by itself is a whole topic of another topic of conversation, but there is a federal mandate that we at least perform a medical screening exam on all patients who come through the door. And, the specific part of that safety net is the fact that we are honestly the only point of access for a lot of vulnerable and marginalized patients. So how is this kind of solidified in the literature? In March of 2000, the Institute of Medicine put out a report entitled America's Healthcare Safety Net, Intact but Endangered. And it really defined what we would call core safety net providers. So these are providers either by legal mandate or by mission maintain this open door policy. The report solidified much of what we just said, that we see patients regardless of the ability to pay, and we provide services to uninsured patients, Medicaid, and other vulnerable patients. So the way this really translated in the research and in the literature is about a year later, two leading researchers at the time, Dr. Richardson and Dr. Lang, took a kind of a play on this report and basically started to ask, how is the safety net working and how is it potentially unraveling? And it was really a call to action. And since then, health services researchers have really grown the body of literature on this topic. Emergency medicine physicians are nothing if not innovative and MacGyvers. So as you can imagine, there are all different types of ways we have named health services research. We've talked about, as I said, and as mentioned in my bio, I specifically categorize this as public health and health services. There's been a lot of talk on preventative healthcare. So what does that look like in the ED? So some very common examples. So primary healthcare, as most people know, is the idea of preventing disease. A classic ED example that we do, probably daily, if not hourly, is providing a tetanus shot for patients, right? Somebody cut themselves on a rusty metal. We provide a tetanus shot to help prevent tetanus disease. Secondary prevention, or that idea of early disease detection before it becomes potentially complicated, is at-risk alcohol use. So you have a patient who comes in intoxicated. You've noted they've come in intoxicated, every other day for the last week. Is this a sign they may have alcohol use disorder? And that's an opportunity to intervene. And then another example of tertiary care, which is the idea of preventing complications of disease, is a patient, let's say, who comes in with DKA. While they have DKA and we'll medically treat them for that, providing them things like meds to beds to get that insulin to them, which they've been lacking, which led them to DKA, is a classic example of tertiary prevention. Another name of this that we've seen a lot more in the academic space is called social emergency medicine. So looking at individual medical care, but in the context of the patient's social environment. So what are their social determinants of health? Are there food insecurity concerns, housing insecurity, lack of transportation, things that will really hinder their care, potentially in the ED, but definitely once they leave. And then given the fact that patients come to us and we have this whole population, we have a lot of opportunity for population health and looking at that from a health services lens. So speaking of these different lenses, there are a lot of different ways to slice this. We in emergency medicine, specifically academic emergency medicine, held a consensus conference a couple of years ago that looked at a piece of this, looking at racism through a diversity, equity, inclusion lens, and saying, what does racism look like in our upcoming research agenda? A few years before that, we took a kind of sex and gender lens, looking at what that looks like both operationally in the ED and also specifically emergency medicine research. There are also ways to look at this through different disease processes. So as an example, this was a specific review article looking at what are the research priorities for a group of patients with substance use disorder. Um, and then there's also been a huge surge in literature looking at health services from a technology aspect. So using things like natural language processing, identifying health services needs through notes that are embedded in the EMR, or as you may see in Epic, in one of the tabs, you can see if a patient has specific social determinants of health, if that's filled out. That shows what are, potentially food insecurity, housing needs, things like that. So lots of ways to kind of tackle health services. So with that, I'll just to kind of simplify it, so our heads don't spin. I'm looking at it from how we at UH define health services in our Health Services Institute, and that's in four main categories: disparities, outcomes, promotion, and technology. So I'll use that framework specifically as we talk about two specific subgroups, and these are patient populations that I've really spent the majority of my career researching and performing implementation science research on. So the first one is HIV screening. So let's talk a little bit about the story of HIV screening in the ED. So we'll start in the kind of early 2000s. When we look in the literature, in the early 2000s, HIV care in the ED was really focused on diagnosis, opportunistic infections, and post-exposure prophylaxis. So having that patient come in with kind of vague, non-specific symptoms, trying to identify, is this acute HIV infection, and providing diagnostic testing. For a patient who may already have HIV and or AIDS, the identification of opportunistic infections was really important. How do you identify them, diagnose them, treat? And then kind of on the other end of the spectrum, let's say if a healthcare worker had a needle exposure, what do we do in the emergency department when they come in? And what does post-exposure prophylaxis look like? And that was really the sum of literature in the early 2000s. 2006 was a pretty big year on a national level, in that this is the first time the CDC mentioned emergency departments from a testing perspective. So in their morbidity and mortality weekly report, they had revised recommendations for HIV testing in healthcare settings. And they specifically said, called out recommendations for HIV testing is intended for all healthcare providers, including those working in hospital EDs. This is the first time specifically EDs have ever been mentioned for HIV testing. In prior guidelines, they had talked about kind of inpatient and outpatient settings, talked about some of the specifics on counseling, testing, and referral, and specific patient populations, but never in the ED setting itself. So as you can imagine, the next decade and a half, there was a huge boom in literature, looking at everything on, including how to do this, when to do it. Is it in the beginning of the ED encounter when the patient is being triaged? Where to do it? Is it in triage room? Is it in the patient's room? And the other big question is by whom? And we'll kind of touch on this throughout the presentation, but the idea that providers could potentially do this, but they are also, managing all of the other acute issues and acute care needs of their patients in the ED. So this idea of setting up adjunct parallel staff, whether they be linkage coordinators, social workers, community health workers, research assistants, who are able to help with that testing, that education, and then that linkage to care, is something that we saw kind of evolve over time. The next kind of big milestone, I feel like, in HIV research, was the announcement of the ending the HIV epidemic in the United States in 2019. This was a federal initiative spearheaded by the Department of Health and Human Services with a fairly lofty goal of ending the epidemic by 2030. So we have a few more years to go. But this initiative had a lot of federal funding behind it. As you can imagine, once you have federal funding, it really helps to kind of move the needle in terms of health disparities and outcomes, and puts a lot of kind of momentum behind that. More looking internally in the emergency medicine field, one of our largest professional organizations, the American College of Emergency Physicians, or ACEP, announced or revised their policy statement in April of 2023. So their policy on bloodborne pathogens in emergency medicine had been present for many years. But in 2023, they came out with probably, yeah, similar to the CDC, kind of the strongest recommendation, which was saying universal opt-out HIV screening in populations, including pregnant patients, is encouraged. Before then, really the only discussion of HIV was testing those patients who are at risk, but nothing that indicated universal opt-out screening. Specifically, opt-out screening is this idea that as part of your medical care in the ED, you could be tested for HIV unless you specifically said you did not want to be. They even took this one step further and said that EDs should try to provide rapid antiviral treatment when possible. They suggested that ED physicians consider talking about HIV prevention, or PrEP. And they really wanted to shed a light on this idea that separate consent for HIV testing needed to be reevaluated and essentially removed, because this was a huge stigma around HIV. If I'm consenting you for care in the emergency department, I don't consent you for every single thing, a CBC, a renal function panel, a chest x-ray, right? You get consented for all of the care, and HIV should be no different, because having that separate consent is very stigmatizing, potentially in an environment where it may not be super private. That was a big barrier. So looking forward, we have to think, what does HIV care look like, both now and what will it look like in the future? I think some of the things that we have seen are this idea of starting to put some quality metrics behind this. Just a couple of weeks ago, we got back from the American College of Emergency Physician 2024 conference. And now that this policy has been changed, revised, there's been a lot of talk of putting metrics behind this. So kind of a first potential metric would be, if a patient comes in with STD concerns, you'll look to see, has this patient been tested for HIV, indicating that this is, kind of part of this quality bundle. I think EDs will, continue to get funding for screening, linkage to care, and prevention. One of the other things we'll talk about in a few slides is this idea of targeting the ending the HIV epidemic in certain areas of the country, those that are seeing the highest prevalence of new HIV diagnoses. And then HIV prevention, both counseling as well as biomedical prevention in the context of PrEP. So myself and a few other colleagues wrote an editorial in Annals of Emergency Medicine looking at what this next wave of emergency medicine HIV research will be. And we think a lot of it's going to be focused on prevention. So going back to our 4 categories, the first one we'll talk about is disparities. So there are significant racial disparities in HIV care. When you look at the incidence of new HIV infections here on the left, in comparison to the racial population of that group in the US, you'll see Black African American patients make up 40% of new HIV infections, but only 12% of the US population. Similarly, Hispanic Latino patients make up 29% of new infections and only represent 18% of the population. So we have some work to do here. Women are also represent an area of health disparities. Surprisingly, women make up only about 19% of new HIV infections, but their mode of transmission is particularly concerning and an area rife for health promotion. So the majority of women acquire HIV through heterosexual contact. There are definitely days when I'm in ED super track or fast track where I feel like I'm doing more sex ed than clinical medicine, just because there's so many opportunities to talk to young women specifically about how to protect themselves from STDs and HIV. Another group of risk category that we've made, again, some headway on, but it's still there, is the different types of risk, ways that you can contract HIV. So the majority of HIV infections are still among gay, bisexual, and other men who have sex with men. 22% are reported through heterosexual contact and 7% through IV drug use. Now, over the last 4 years, between 2018 and 21, as you can see here in each of the risk groups, numbers have fortunately overall been trending down. While not zero, we still have about 6 years to go, but numbers are trending down, which is good among all 3 risk categories. Lastly, there are geographic disparities. So within the EHE initiative, they identified priority jurisdictions. So these are either counties, which are the blue dots, or whole states that have a significantly disproportionate number of new HIV infections. So as you can see here in Ohio, it's the 3 Cs, Cincinnati, Columbus, and Cleveland were identified as priority areas. But the South is specifically definitely concerning. And I think this is going to be a more targeted area in the future. The stigma of HIV testing and treatment is huge down there. And it's something that they're continuing to battle, even now in 2024. So looking at outcomes back in the 1980s, the CDC and Health and Human Services came up with the HIV care continuum. So this is, kind of, as you can see, this kind of stepwise fashion. Of course, you would want this all to be the same or trending up. So the number of patients who are diagnosed are first identified, and then those who are linked to care. The question is, did they attend the appointment? Did they get started on antiretroviral therapy? Looking at the blue bar, were these patients retained in care? And they define retention as at least 2 tests about 3 months apart. And then is the patient virally suppressed? I can say anecdotally, specifically at CMC, the biggest kind of gaps that we see are that linkage to receipt and retention in care. We have the majority of our patients that are identified as HIV have known HIV disease. It was not newly diagnosed. But they have a lot of comorbid conditions, so substance use disorder, mental health disorders, and social determinants of health that hinder their ability to get to that appointment, start meds, and maintain meds. With regard to promotion, this is always a double-edged sword. We would love to be able to spend an hour with our patients to talk to them about HIV screening and testing, but time is limited. So we have different ways that we try to help promote this education in the ED. The U equals U campaign has been, monumental in helping that. The idea that if you are HIV positive, if you start on medications, you can be undetectable, which is equal to untransmittable. A few years ago, we put up a big kind of plastic wall of flyers in the waiting room. This pole here is one of our many wheelchairs, and you can see in the background is right across from the vending machines. So it's prime real estate in our waiting room. And we have flyers on HIV treatment, prevention, PrEP, condoms, in multiple different languages. And these are refilled not infrequently. And then hospitals, health departments have done a ton of messaging, trying to get people to think more about HIV treatment and prevention in various different formats. Okay, looking at this from a technology perspective, so we all have an EMR in some way, shape, or form, right? So there have been a lot of really good ways to leverage technology for HIV screening and linkage. One is using BPAs or best practice advisories. where you are notifying the provider, like in this case, in this particular article, they had a BPA pop up if a patient came in with an STD infection, reminding the provider, hey, do you also want to order an HIV test? And this was a similar type of alert that happened in a more rural kind of Appalachian emergency department. So not necessarily like your big academic centers. Another big way that we have leveraged technology to help with screening and identification is having algorithms that run in the background that identify patients. But then you have to do something with those algorithms, right? So it could be a text message alert, an in-basket message, a flag, something of that effect. And we've seen all forms implemented in EDs in the literature. So in this article, we piloted this out in Cincinnati, where we had an algorithm that identified patients who had had a previous abnormal, or in this case, positive HIV or hepatitis test, and it sent a text message in real time to our adjunct staff, who were able to go down to the ED at that time and identify the patient and determine if they were in care or if they needed to be relinked to care because they had, for whatever reason, not continued their medication and needed to be re-engaged. And this is something very similar as well. But with technology, there are two sides to every coin. And so I think on the other end of this, and this is where the implementation science really comes into it, is thinking about alert fatigue, right? So we were not the only ones to come up with these ideas. We have alerts for all of the acute medical issues that you can think of: sepsis, strokes, STEMIs, right? So whenever we're thinking about implementing this, we have to be cognizant of the fact that this is one of many alerts. And often we need to prioritize this with our other acute medical alerts that are out there that need to be, recognized without causing alert fatigue from providers. So what we've done here specifically at UH and all of our emergency departments, we have this new column that you can add to the track board that identifies patients here on the far right. You can see the column that identifies patients who are at risk. And this is based off of CDC criteria. So the idea that every patient or every individual should be tested at least once in their lifetime, or if they're high risk, they should be tested annually. And so this flag pops up. It's something, again, providers could be aware of, could act upon, or in our case, our adjunct staff, who are community health workers, will identify these patients based off of this algorithm. So in summary, myself and my team have various different forms of funding to help to support HIV linkage or screening and linkage to care. And it's really through this longitudinal, kind of 10 plus year career of implementation science where we've been able to hone best practices for all of these. Now, interestingly, we'll see how the HIV epidemic in the early 2010s started to collide with the opioid epidemic, in our next case example. So while HIV focused a lot on screening and linking patient to care, the case example of opioid use disorder really focuses on treatment initiated in the ED and things that we can do while the patient is there to get them to that next step. So we'll go through this timeline. The top portion of the timeline are kind of national trends and waves that helped to really shape what happened in the bottom timeline, which is going to be the emergency medicine-based research aspect. So in the 1990s, we unfortunately saw a big surge in overdose deaths caused mainly by prescription opioids. While I was not practicing clinically at that time, there was a big surge in identifying pain as if a vital sign was kind of the tagline, and pain needed to be identified. It needed to be treated early, often. There are anecdotal reports of emergency medicine providers prescribing 30, 60, 90 tablets of oxycodone for, potentially an ankle sprain. So that's, one of many reasons that kind of led to this first wave of overdose deaths. In 2000, government identified that we had the ability to treat patients with opioid use disorder through medications for opioid use disorder, such as methadone and buprenorphine. So they initiated what's called the Data or Drug Addiction Treatment Act of 2000 waiver, this idea that physicians could complete an 8-hour training program in order to learn how to prescribe medications for opioid use disorder that they would not otherwise be able to do with their regular DEA. So this was really an attempt to help to treat patients with, opioid prescription substance use or opioid use disorder. In 2010, we then saw a surge in heroin. So in the early 2000s, the number of opioids that went out really started to decrease because providers were becoming more cognizant of this. But there was now this shift in overdose deaths due to heroin. And then a few years later, a shift in overdose deaths due to synthetic opioids, such as fentanyl. So these were opioids that are essentially made that do not exist naturally. So looking at all of these, epidemics, I think we've all seen in the news the impact this had both on human life, the economic burden, the political burden. There is tons of information in the media, basically up until the COVID pandemic, that talk about the burden of the opioid epidemic. Specifically in the medical field, as of about 2020, only about 5 to 10% of providers actually had gone through this X waiver. So while it was available, it wasn't being utilized kind of to the point that we expected. Specifically in the ED, we had this rule called the 72-hour rule. So we could administer or order medications for opioid use disorder, specifically buprenorphine, but if you didn't have the X waiver, you wouldn't be able to prescribe it. And I specifically remember a patient that came in, it was before I got X waivered, who was released from jail, I think around 7 p.m. on a Friday night. And he had gone through rehab, had been on buprenorphine, was not interested in going back. But he said, my next appointment and my next MOUD appointment is not until Monday at 11. What do I do? So I treated him with a dose of buprenorphine in the ED Friday, and I said, I'm here all weekend. He came back Saturday and Sunday, right around the same time. And while it was great for the patient, it's obviously not a good use of healthcare resources, right? It was not necessarily an ED visit that is, an acute kind of medical concern. But it was something we were able to provide him, so we didn't have to, resort to other means, and it helped to bridge him to his appointment on Monday. In 2023, so having recognized that so few providers were X waivered, this didn't, really have the effect that they were hoping. In June of 2023, they eliminated the waiver, which means they have basically eliminated all of the restrictions, like that 8-hour training and the significant fee, and this helped to expand buprenorphine initiation, because now it's really becoming more prevalent in both medical student education, resident education. So they're getting a lot more exposure to this than we did, a decade ago. So this is kind of the overall national landscape. So now we can look at specifically in the research world. And as you can imagine, there are hundreds of thousands of articles, but I'll just start in 2015 because I think this is where it really starts to set the stage of opioid use disorder treatment in the ED setting. And it was with a landmark article published in JAMA. That was a randomized control trial that looked at initiating buprenorphine naloxone in the ED, and they compared it to either a brief intervention or a standard of care. And what they found is when we initiated buprenorphine in the ED, the percentage of patients who made it to treatment and then were retained in treatment were statistically significantly higher than those who received just the brief intervention and or placebo. So with this, and kind of mirroring as well this surge in both heroin and fentanyl deaths, we kind of saw this collision of the HIV epidemics and then the opioid epidemics. Year after year, different areas were being identified as having an opioid epidemic. So one of the first ones was in Scott County, Indiana. They saw a huge surge in HIV infections, again, all due to injection drug use. Another MMW report came out for the same surge in HIV in Seattle, Washington. And then when I was down in Cincinnati, we also identified an outbreak in HIV in the Cincinnati, Northern Kentucky area, all from patients who injected drugs. To the point that the CDC actually came down and performed an epidemiological investigation to try to figure out what kind of that root cause was. Similar to HIV, the American College of Emergency Physicians came out. This time, I believe they came out kind of bigger and stronger because we were just so affected by opioid overdoses in the ED on a daily, almost daily basis. They had clinical policy, policy statements, toolkits for medical directors to implement in their emergency department, and these quality frameworks to say this is really how we need to start approaching these patients and treating these patients. So in the last 5 years, again, there's been another big surge in literature examining kind of all of these different aspects in that kind of care continuum. So screening, initiating the medication-assisted treatment or MOUD, looking at harm reduction. So this is the idea that patients may not be ready to go into addiction treatment right away. But if they're going to use, let's have them do it safely. So providing them Narcan so they don't, overdose and subsequently die. We also initiated peer recovery coaches in the emergency department. This was something that has been present in the outpatient setting for a while. So we were a little late to the game here. But the idea that peers are individuals who have lived experience with substance use disorder. They've gone through recovery and completed both an online and a hands-on training and have a specific certification to become a peer. So fairly rigorous. And then lastly, we looked at both linkage to treatment and retention to treatment from the ED setting. So similarly to HIV, we want to think about what does the next stage or what does that next kind of wave of research in OUD look like? I think it'll come in a few forms. Again, looking at these quality metrics, how are specific EDs or how are we doing nationally on these opioid use disorder metrics. And I think similar to HIV, there's going to be a big prevention aspect. So what are some other alternatives besides opioid medications that we can provide patients when appropriate so they don't even start opioids if they don't need to in the first place? So looking within our four contexts, we want to identify our disparities, outcomes, opportunities for promotion, and technology. So again, unfortunately, there are racial disparities in opioid use disorder. You can see here that specific populations like Black African Americans and Native American Indian and Alaskan Natives had a disproportionate rise in deaths as compared to other subgroups. Similar to the HIV care continuum, there's an opioid use disorder cascade of care. So it starts with, first diagnosing the patient with opioid use disorder, engaging them with some sort of addiction or OUD services, initiating this medications. In this case, this article was based in the outpatient setting, but I would definitely argue that the ED is the other component of that cascade of care. And then timely follow-up, both within 1 month and then retention, looking at retention within 6 months. Similar to HIV, the idea of promotion has taken a kind of different form in the ED setting than it maybe would in the outpatient setting. So there's this idea of SBIRT, and by definition, it is screening, and a brief intervention. So literally 5 to 10 minutes at the bedside, and then that referral to treatment. This has been very widely studied, specifically in the ED as a way to help to get the patient to that kind of next step. We also do a lot of education on Narcan. We specifically here at UH are funded by the Ohio Department of Health to provide Narcan to patients free of charge from the emergency department. And surprisingly, it's not only the patients, but it's their family, their caregivers, who really say, yeah, I'd love to have this and have it on hand. And so there's a lot of education there. Specifically looking at what we are needing to be most aware of currently is the different ways that these medications are making their way into kind of the mainstream. So as you can see here, this was a report from the DEA called the National Drug Threat Assessment of 2024. And they identified essentially these, what they call rainbow fentanyl pills, which I don't know about you, but they look very similar to Valentine's Day sweeties and or Smarties. So it's a little terrifying, just how these are being manufactured and marketed, in this kind of space. In addition, there are, other things that we try to at least discuss with patients is that while you may be thinking you're buying one medication off the street, or one substance off the street, such as cocaine, it may be laced with fentanyl or xylazine, which, comes in this combination that patients, again, may not be aware of when they're buying this on the street. And another equally scary DEA seizure was these fake Adderall pills. So the prescription Adderall is here at the top, but these synthetically made Adderall pills down below look very similar. And in this case, they have methamphetamine. We've also seen that they can also have fentanyl. So if you're looking for a Halloween spooky story, I would read the National Drug Threat Assessment. It'll scare the daylights out of you. So similar to technology, we have really been able to leverage, or similar to HIV, excuse me, we've been able to leverage technology in both screening and linkage to care in the emergency department. So article after article has again looked at natural language processing, alerts, EHR flags, ICD-10 codes, various things to identify patients. And then we've also used lots of linkage to care mechanisms from something low intensity, like what we looked at a few years ago in Cincinnati, where we provided just kind of that brief referral to treatment, to more intense, warm handoffs to addiction medicine treatment facilities. And there's also been a big boom in literature on having ED-based peers. And this is one of many articles that showed that initiating that peer interaction in the ED really helps with both linkage to care and retention in care. So specific to our shop here at UH, we've really tackled all aspects of this. So with regards to prevention, myself and a colleague at Connor Whole Health received a grant from SAMHSA looking specifically at these alternatives to opioids. And again, this is not new. Alternative to opioid initiatives and practices are taking place on the inpatient side. We're just a little bit late to the game, so we're looking forward to initiating that in the ED. With regarding to screening, again, if you look here on the far right, similar to the HIV column, we have a substance use column that identifies patients using an EMR algorithm who could be at risk for opioid use disorder. With regards to harm reduction, like we said, in most of our UHEDs, we have the ability to send patients out with free Narcan that they can use, themselves, for family, friends, whoever. And we're marking this as, it's not just if you are somebody who doesn't use opioids. If you use marijuana, it could have fentanyl in it. If you use cocaine, it could have, fentanyl or heroin in it. So this is one of the many harm reduction funded efforts that we have. And the last one is linkage to care. So we also have dedicated peer recovery coaches in the ED. We have dedicated peer or dedicated substance use navigators, and we have a specific clinic within the Center of Emergency Medicine run by our toxicologists to help to transition patients from the ED to longer term MOUD kind of maintenance. So with that, I would like to just kind of point out that, again, myself and colleagues, we have a significant amount of funding from kind of all different sources that helps us implement through implementation science these best practices in both HIV and OUD screening, linkage to care, and prevention. While the ED is a great place to do this because we have the patient population, we have the needs, and we have the resources, it's also really difficult, right? It is not the ideal place. We're doing it out of necessity. We're doing it to help our patients. But we are constantly struggling with our acuity, space, with boarding, volume, and really establishing that trust. But this really is the most kind of poignant point of impact is ED. As we know, this is a start, right? Like we can start these efforts here, but once a patient leaves ED, this is where we need, collaboration and partnerships with our other kind of service lines to help kind of take that ball and run with it. But the impact on research and the impact on patient outcomes, cannot be overlooked with, again, many more years of health services research to come. Here are my references. And with that, I will take questions. Thank you.
Fantastic job. That was a really, really informative talk on behalf of everyone. If anyone has questions and they wanted to drop them in the chat, I can go ahead and get us started. It looks like there's one from Vicky Noble to start, who says, fantastic job, Dr. Faryar. We're so lucky to have you here at UH. How can students or residents get involved in your work?
Absolutely. Thank you, Dr. Noble. So I think the main way would be just to contact our division. We really try to match residents and students' interests. Again, being in the ED, we have a broad spectrum of research topics to think involved in. So we'll kind of ask them what are their interests and try to find a project that we either have ongoing or that they could start that matches those interests. So yeah, definitely contact myself and I'll kind of gear them in the right direction.
Okay. I have a question while waiting for more to come in. So yeah. I thought you did the beauty of implementation science is it seems like it's like so simple and straightforward, but it really there's a lot under the surface that goes into it. And I was hoping if you could just sort of speak on what you think were a challenge with either project that sort of one of the challenges of navigating and implementing these things that you sort of maybe didn't expect and sort of how the biggest challenge you faced with either in or both.
Yeah, and absolutely right. It's a word that when I went into it, I didn't, fully kind of grasp the concept of it. And it's different because it's not like your typical randomized control trial. You're not investigating new things. It's really a matter of application. How are you applying these best practices in a potentially new novel setting? I think it's really those intangibles, things like the culture of the emergency department. Again, you'll have those ED providers who are really, open to this idea, and others who say, the ED is for acute medical care only. And, I don't have the time, energy, kind of bandwidth. And that's why things like the adjunct health professionals really help. And embedding them in technology in the EMR really helps. So those kind of intangibles, how do you shift culture? I think were probably some of the biggest challenges because, things like implementing grants, protocols, workflows, that's, kind of the pen to paper. That's
exactly,
quote, easier than those intangibles for sure.
And like culture changing is so hard. And especially like you present the case that, yes, it's not acute medicine or acute medical need, but like, guess what? These patients are coming in over and over. So if you can prevent, and it's hard to quantify that and sort of change your culture. So I get that. It looks like there's a question from Marwa Badir.
Yeah, go ahead.
Yes, thank you very much for the presentation. My question is, if somebody located in a different state, say I am located in New York and I would like to be maybe an extension to collaborate, gather data from the whatever emergency departments here in the hospital that is close to me, like maybe NYU, Winthrop, or NASA Medical Center. Is there's any way I can be part of gathering samples for you to be part of collaboration, or this is or this is not possible?
Yeah, absolutely. Much of my work is collaborating with fellow emergency medicine health, services researchers from across the country, right?
Okay.
Because there are, because, and in every one of these, in the literature, you look and say, well, this is what happens in my shop, but I can't say this is necessarily generalizable, right? So if we say it was not only here, but in New York, there's some more generalizability that you can put behind that. I think again with things having things like the EMR where you have standard definitions, standardized data reporting, I think that really helps to make sure we're all kind of speaking the same language in terms of patient outcomes, disparities, things like that. So absolutely.
Would you mind posting the email that we can contact you through, or
Yeah,
the phone number?
Yeah.
Thank you.
I think that will be available
at the end of the
Grand Round series. Absolutely.
Yeah, okay. We'll be able to share. I have a question, Kiran.
Yeah.
Great presentation. Thank you for sharing what you do. I want to hear your thoughts on, the importance of educating the younger generation, like high school kids and college, right? Are there any efforts going on, especially within UH, to sort of like community outreach and then let them know that bring these issues, risk awareness to the younger generation? Because those are, I would say, vulnerable populations. They are curious about it, but they don't know what the risk associated with it, especially the picture, the rainbow candies. As a mother, when I see that coming, that Halloween is coming, I will be really freaking out if my kids bring them back home, right?
Yeah.
Like, what are your thoughts on, what we could do as a healthcare providers to educate in the community outreach in terms of the educational efforts of that?
Yeah, absolutely. I didn't, have time to kind of go into that. But we do a ton of outreach, both within the Department of Emergency Medicine. I talked a little bit about DEI, the diversity, equity, inclusion. So we have a DEI team here within our department. And as you may know, we have a university hospitals wide DEI. And so we go out and we do a ton of outreach, and we really incorporate kind of all aspects of emergency medicine. So, examples would be we went to a high school to kind of talk about what is medicine, what is emergency medicine. We had 4 different stations. We had a CPR training station, right? Kind of classic bread and butter emergency medicine. We had a stop the bleed station. So how do you put on a tourniquet? We also had a Narcan station. This is what Narcan is. This is what it looks like. It's like Afrin nasal spray. These are the indications for when you would use it. And, so this is how we incorporate it into that community outreach, just making it one of the many talking points of, kind of the bread and butter of what we do in the ED. We go to the UH Family Health and Safety Days, and again, talk about overdose education, Narcan distribution. We have HIV test kits that we can actually, this is many of the boxes behind me, that we can send patients out with to test themselves. And we give them the phone numbers, the business cards of our community health workers, and say, contact us either good, bad, or ugly, right? After you do this test, because we can help to link you to the care that you would need for either prevention or treatment. So yeah, just incorporating it, I think, really into what we do for all of the emergency medicine training, and really trying to not stigmatize it, and adding it to things like our classic CPR and tourniquet training.
I was wondering what these test kits were behind you, so I'm glad.
Yes. Yeah, I have a wall of Narcan and HIV test kits that I store for set events.
That's why you're in the right place.
Yeah.
Does anyone else have additional questions for Dr. Faryar? Hey, well, it looks like we're gonna wrap up a couple minutes early here. I want to thank you on behalf of all of us for taking the time to talk with us today. Absolutely fantastic talk, and I'll be emailing you offline because I think there's a lot of space for collaboration for us.
Sounds good. I appreciate it. Thank you so much for the opportunity.
Bye, guys. Have a great day, everyone.